Okay, good morning. We're going to do this surgical day for cataract. This is a post-hyperopic LASIK patient in English. So some of our outside Greece friends can follow this. We're marking the astigmatic direction for the toric lens, 2.75 incision, viscoed manual capsulorhexis. Nothing really remarkable here. This patient I had performed hyperopic LASIK close to 20 years ago for about +2. So difficulty with the formula. We're going divide and conquer, and the procedures, all procedures today are speeded up ×8. So I apologize for the speedness, but it's mainly to make them easier for people who are not familiar with eye surgery watch, but also get the basic principles. So the nucleus is out, and we can all appreciate this was a significant cataract for the patient. His vision was down to 20/70, and he was still driving. We'll pretend we never heard that. Using my split with my left hand, remove the cortex under my main incision. I like this trick. Nice bag fill with methylcellulose. I'm coming in, polishing the capsule. Here I'm filling in with methylcellulose. We're using a toric intraocular lens, fold the lens, and I still do all these steps myself manually. Want to make sure everything's as good as possible. I'll come in, I'll go under the lens, clear any debris and the residual viscoat, and over the lens, very careful in removing most of viscoelastic, and now come in and center the lens, hydrate the incisions, and we have a very nice case. Patient feels comfortable, wants to do the other eye, will jump directly to the right eye as well. I'm recentering here. Right eye now, it's a T3 at 91 degrees. Our angle measurement, I go in always at 135, and this is embedded in my formula. Again, almost a copy of the previous procedure, just the lens power changes. We opted, this is his non-dominant eye, to aim with about a -1.5. I'm very keen in working with astigmatism in most patients. I have an impressive statistic of using 90% toric intraocular lenses, and we play with mild blended vision, planar to -1/2 of the dominant eye, and this enables us to have visions better than 20/20 since we're using toric lenses. Nucleus is out, we're coming in to remove the cortex here, and I was saying that the non-dominant, we're aiming mainly somewhere towards the -0.75, again with full astigmatic correction. I'm a big believer of this, and we're getting data that are comparable, if not better, than with EDOF and very close to trifocal lenses without any of the problems with quality of vision and contrastivity that those lenses have. So again, under the lens, over the lens, remove the viscoelastic. Another uneventful case. A little blemish here behind the lens. I want to make sure it's out, hydrating the incisions. Again, patients need not to rub their eyes the day of the surgery in 5 days on topical afloxacin and a antibiotic dexamethasone combination um, drop. Very careful to make sure my incisions are watertight. Again, very meticulous in the axis of the toric lens and make sure that the lens is captured by the bag. Patient is done. We're going into a next patient, a little older. We can tell this is more of a cataract rather. Same technique, coming in, incising the anterior capsule, continuous curvilinear capsulorhexis, courtesy of Dr. Thomas Neuhan of Munich. I'll never forget the first time I saw the video of his procedure and him introducing this procedure. Obviously, I was very privileged to have trained in New York City and operated on the actual room that Charles Kellman developed his cavitron and phaco surgery. And here we are so many years later using his technique. Also, a surgical microscope that was brought into ophthalmology by Dick Troutman, another Manhattan Eye, Ear, Throat Hospital giant. From what I know, the two of them did not do very well together, but this is past history. We're both students. Actually, we are students of both of these giants of ophthalmology. We own so much. Again, here I'm cleaning up the residual cortex with my left hand. My piano lessons when I was in elementary school did help me a little bit in this regard. Again, bringing in the lens, I do this all by myself still, placing our lens. This is a non-toric lens, so I place it horizontally to remove, to reduce rather negative dysphotosopsia um, symptoms for the patient, since the haptic will be temporarily reduce this very bothersome symptom that some of these patients have. We have a very nice procedure, same precautions. Again, I apologize for the speed, but this way will fit a lot of cases, and these are non-selected conservative cases from our office. All right, challenging. 80-something-year-old lady. Obviously, she took her time to have her procedures done. She's count fingers. We've tried an image of the macula. There seems to be no macular problem. She has significant astigmatism. I'm very careful here. Very small incision initially. I'm using epi. The pupil does not move. Air, you guessed it, blue. And I'm going to come in with a 30 gauge needle initially because I'm afraid the lens is intumescent. So I will incise the anterior capsule with a very tiny incision, and without a paracentesis, there's no leakage of cataract milk. So obviously this was not an intumescent lens, just a white lens. Deep breath, enlarging my incision to 2.7, also placing a paracentesis of 1 millimeter, coming in with my Utrata forceps, and blue helps me get a very nice continuous curvilinear capsulorhexis hydrodissection. And here we're going with our signature device. I love this device, very gentle for the cornea. I'm kicking up the power to 80%, and I'm being patient here. We need to give time here. The lens is very big. It's pressing upon the capsule. The thickness of the lens is over 5 millimeters. So this is a case you want to take your time and not have to spend time picking up pieces from the vitreous cavity. I'm always filling in more viscoelastic Viscoat. It is a savior for corneal endothelium. So even if I'm at 200 joules total energy here, a big cortical shell left behind, I'm going to try and tease it out here with fluid and go in again with my phaco tip and save time, remove it en bloc. Essentially no cortex left. I'm going to, in lieu of not putting the capsule in danger, this patient also had pseudoexfoliation. I'm able to fulfill the dream, use a toric lens here. So this patient is going to be up for a big surprise from barely count fingers to why not, if the macula is as it looks at OCT perfect, she may reach 20/20 even better visual acuity. Everybody deserves it, even in your 80s. That's our philosophy. We don't consider these premium surgeries. These, as you can see, are routine surgeries, watertight. Next patient, a T4 again. This is the against the rule day, I guess, today. Putting here our marks. Different patient, same story. We have a significant cataract here, incision at 135 always, and this is embedded in my IOL calculation protocol. A continuous curvilinear capsulorhexis. Again, very nice, centralized. I've commented on this before. We used a femto to do these rexes, but you know, I have found that manually they're stronger, and we've shied away from using the femto. We had problems also using it after the peribulbar anesthesia. All these cases have peribulbar anesthesia here in Athens, Greece. We can't really do these procedures without. Patients squeeze a lot, and you can see that at the end of the procedure, I need a deep chamber and a calm patient to be able to center my lens. Moving the cortex here, polishing the posterior capsule, filling in with methylcellulose. Here's our lens, slightly hyperopic patient, significant astigmatism though, over 2 diopters on the lens. Lens folded, in place. Remove the residual viscoelastic under the lens. Very important step here. Sometimes this may pop the lens into the sulcus. You have to be very careful and recognize that and replace the lens in the capsule bag. Otherwise, you'll have a zigzag lens and poor centration, maybe astigmatism. I think this is one of those cases. Yeah, the lens had popped in the sulcus. I'm realizing it, and I'm putting in this haptic back in the capsule bag. Everything in place. Little looks like 2 seconds delay, but case great. Again, another case. These are consecutive cases. They're not selected. This is a T5 toric lens, so we're talking about 3 diopters of astigmatism. And again, we're basing our data on preoperative cornea tomography, and also the IOL Master 700, which is spectacular in IOL calculation, through the very nice cornea imaging that it does with total corneal power. We have compared this to our Pentacam total cornea 7, actually 4.5 central keratometries, and it's very similar. Divide and conquer here in 2 pieces, so lens is not too hard here, so I'm bringing up the pieces, back chop the second half, remove the nucleus pieces, and now with our IA, I was talking that previously in regard to the signature WideStar device, my go-to device. My lenses obviously are Alcon, and we use the best technology for each patient as far as I'm concerned. We're seeing here significant subcapsular debris, which I'm polishing with after I'm putting methicellulose with my IA. Again, the significantly toric lens, same technique. And this is the key of successful surgery, I think, to be very consistent. Again, under the lens, remove the residual viscoelastic, very careful, since I'm using a lot of visco, to remove it so we don't get IOP spikes the day after. Also very meticulous in centering the lens. Going in back, also have the lens captured by the anterior capsulotomy. Same story, different patient. Again, this is a non-toric lens. So a record for us today, I think we're seeing here 8 cases, and 2 or 3 of them are non-toric, which is unusual. Usually we're 90% toric, as I mentioned before. And I'm going to reiterate the fact that we're playing with blended vision, a planar to minus 0.4 in the dominant as endpoint, and minus 0.75 of the non-dominant. Excellent stereo vision, excellent distance vision, by being very meticulous and vigorous in correcting astigmatism with the toricity of our lenses. This is not a blemish on the capsule. This is probably residual of the hyaloid artery placing in the lens. I was saying that we're able with blended vision to have better than 20/20 with both eyes distance, and close to J2 at near, without compromise at all stereo vision and quality of vision that an EDOF or a multifocal lens would. But I know this is personal preference. This is a younger patient in his 40s. He remembers being punched in this eye. Unfortunately, what they have not told him is that he has significant angle recession. We diagnosed him yesterday. He went on directly to have the surgery. We can see the lens is quite dense. Remarkable. The other has no cataract at all. He's almost 20/200 in this eye. The only challenging thing here is the capsular excess. I should have probably put blue in, but I'm being a little careful, doing very well with the capsular excess. And again, the other concern here is if there's any zonio desistance. So I'm going to be very careful in spinning the lens, and when I go in now, I'm careful to ascertain if the capsule is intact, and it is, and the zonioles are intact. The lens is very opaque but quite soft, as you can see. So again, same technique. I'm always breaking to put in viscoelastic. Very important point, because once you're left with small pieces of the nucleus, you can easily grasp the posterior capsule and have it rent. And there's no reason to do this. It takes only a few seconds to go in and refresh the viscode, and we're always very non-frugal with that, because we like the cornea safety that it gives us. Methicellulose, fill the bag. Toric lens, we aim to a -1/2 on this patient. He's 48. He'll be presbyopic in his other metropic eye. The -1/2 will help him in this eye to have very good distance vision and help with computer vision up until his mid-50s. I don't foresee his other eye undergoing cataract surgery anytime soon. So he'll probably be a pseudophakic in one eye only. Procedure, again, same principles. You're seeing how meticulous I am with it, be watertight. We're all done here. Thanks for watching. This is John Kanellopoulos, Clinical Professor of Ophthalmology at NYU Medical School, New York City, New York, and the Medical Director here at our LaserVision Ambulatory Surgery Center in Athens, Greece. Thanks for the company. Hope you enjoyed it. This is John signing off.